The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and thank you for joining us today. You have logged on to the Nelson Labs webinar, Microbiological Updates to ISO 11137-1, demonstrating stability in bioburden numbers and types. Just a few housekeeping items before we go ahead and get started today. If you ever miss one of our webinars or want to refer back to it, you can always find them on the Nelson Labs website on the on-demand webinars page listed under education. You can receive notifications for upcoming live and on-demand webinars by liking Nelson Labs on Facebook or following on LinkedIn. We also invite you to register for free for the Sotera Health Academy at soterahealth.com/academy. There you will find curated content from industry thought leaders, everything from introductory sterilization and lab testing topics to advanced in-depth learnings. Our expert advisors have filled this academy with cutting-edge educational content and resources to help you mitigate risk, go to market faster, and achieve excellence in your field. You will also be able to find this webinar in the academy as well. Nelson Labs is a leading global provider of laboratory testing and expert advisory services for medtech and pharmaceutical companies. The company performs over 900 rigorous microbiological and analytical laboratory tests across the medical device, pharmaceutical, and protective barrier industries. The experts at Nelson know every test matters and requires solutions to complex problems to improve patient outcomes and minimize risk. So let's get started for today. Today, we're joined by Martel Winters. Martel is a specialist microbiologist on the Nationally Registered Certified Microbiology and a radiation specialist with AMI. He has been at Nelson Labs for 30 years and spent his earlier years working in the radiation sterilization group, responsible for bioburden testing and radiation validation studies. His specialties include microbiological process validation and radiation sterilization of medical devices, allograft tissue, and pharmaceutical products. Martel is a participating member of AMI sterilization working groups and is the U.S. representative to ISO for 3 working groups. He is the convener of ISO WG Working Group 16 on vaporized hydrogen peroxide sterilization. Martel's participation on domestic and international committees allows him to bring a unique perspective to the industry by elevating the standards for safeguarding global health. We do encourage your questions during this webinar, and Martel will try to answer as many as he possibly can in the last 10 to 15 minutes of this event. And you submit those through the questions tab on your portal. So I will turn the time over to Martel.
Okay, thank you, Mike. Well, welcome everybody. Welcome to my home, and look forward to talking about this interesting topic. As many of you might know, our new version of the Radiation Standard Part 1 was just published a couple months ago, and I want to focus on one of the fairly significant additions to that. So let's get right into it. In 7.2, what used to be 7.3 in the old version, that's where we're going to be focusing largely today. I'm going to start by showing some background, some of the science behind why we were where we were and where we're going, and then show some case studies, and then, like Mike said, have some time for Q&A afterwards. So the previous version of the Radiation Part 1 was 2006. There had been some amendments and some reaffirmations, but we had not done a thorough review since 2006. So it was really needed. And so I want to call, you see there's a lot of text on the next few slides. I'm going to call out just some of the more critical stuff. So in 7.3, we talk about that a system shall be specified, that the bioburden is controlled, and the effectiveness of this system, of this bioburden control system, shall be demonstrated. And then that's in 7.3 in the previous version. And then for those of you that know, in the annex, the way we've been aligning these in the ISO standards recently for quite a few years is like Annex A 7.3 provides guidance for what's in 7.3. So the guidance in the annex is that the intention is bioburden is stable and low. So you see there's not a lot of guidance in here previously on this topic of controlling bioburden and demonstrating effectiveness. So let's go back in time a little ways. 1977. I was alive at this point, but I was in grade school, so not involved with radiation sterilization yet. And at this point, the industry was still trying to figure out how they were going to go about establishing radiation sterilization doses. Some were just picking a dose and doing sterility testing. Some were actually using 25 kilogray and saying if we use 25 kilogray, everything's good. And so in 1977, J&J hosted a conference here on sterilization by ionizing radiation. And one of the foundational chapters in this book or talks at this conference was from John Masefield and James Whitby. The pictures are down below. And fortunately, I did know both of them fairly well before they passed away. What they said was that the proof of the sterility assurance level requires extensive product bioburden knowledge. Now, I think it's safe to say that largely we've gotten away from having extensive product bioburden knowledge. We've made it so simple with this cookbook approach to establishing radiation dose. You do bioburden, you do verification dose, you test the sterility, and then you're good for 3 months. That we've gotten away from the mindset of how do I really establish extensive bioburden knowledge. So a little more historical information. So previously, what it said in 12, so 12 is frequency as regarding what you're supposed to do on an ongoing basis. So 12.121 said if your bioburden is greater than or equal to 1.5, then you should test bioburden every 3 months. Now this is not dose audits, this is just bioburden testing every 3 months. So that meant if your bioburden is equal to or greater than 1.5 CFU per product, that you're just doing bioburden associated with your dose audit, and that is sufficient. Now, for bioburden less than 1.5, and a couple caveats there if you're using method 1 or VD-max 15, and that was later extended to 17.5 with VD-max, then the maximum time should be 1 month. So that meant that if you had low bioburden, you were penalized by having to test bioburden more often. I'm going to get into why that was the case in the next slide. But you were penalized for having low bioburden, and as an industry, we felt kind of bad in recent years because we realized low bioburden does not happen by accident. Low bioburden happens through a lot of time and effort, and so as a manufacturer, you're putting time and effort into having low bioburden and then being penalized by having to perform bioburden more regularly. Now, and that can be okay, but the problem is there is no guidance or no specification on why to test more regularly and what you should be looking for in those data. So there was this requirement, but with no information as to why and how. So at the ISO level, we really want to remove that consistent penalty for low bioburden products. But there's some potential issues with really low bioburden and low radiation doses. So we got to do something instead. I'm going to go back again, talking about some history. So up here in the top right, you see we have, that's what we call the standard distribution of resistances for radiation. This is the backbone to both methods 1 and VD-max. And it just essentially says that, for example, a D value, so resistance to radiation, a D value of 1 kilogray, that we expect most bioburden from most products to have a D value of 1 kilogray with about 65% of the microorganisms on the product. So about 65% should be 1 kilogray or less. So very easy to inactivate with radiation. And then as the resistance of microorganisms increases, the frequency that you should see those decreases. Now, I'm not going to get into too much detail here, and with this detail or any detail, I'm more than happy to have more in-depth discussions. You're welcome to reach out, set up a meeting, and we can talk about this cool radiation science all you want. I love talking about this stuff. But just to conceptually, just to understand, what they did to try and understand, they did some computer simulations to try and understand whether the approach that they were proposing here was going to work or not. And they did what we call this pass-fail scenario, where mathematically you say if your product bioburden follows exactly this standard distribution of radiation resistances, the way that it's established in the standard, if your bioburden follows that exactly, then, or less in resistance, you should always pass at the verification dose experiment, so pass your sterility test. And mathematically, that should also result in a 10 to the minus 6 sterility assurance level. So when you pass a verification dose and mathematically your sterilization dose is hitting at least 10 to the minus 6, if not lower, meaning like 10 to the minus 6.5 or 10 to the minus 7, then we call that a pass-pass scenario. Now, a pass-fail scenario is a challenging thing, because mathematically you can pass the verification dose experiment, but if you calculate your SAL, you're not hitting 10 to the minus 6. You're hitting something greater, like 10 to the minus 5.5 or 5.8 or something, but not 10 to the minus 6. So we call that a pass-fail scenario. And again, I'm not going to go into any more detail than that, but just what they did, you'll notice on this table to the right, historically, this is from 1998. Historically, they found that if you take population C and if you change those numbers, if you start tweaking things in population C, for example, if your bioburden has a high number of one particular type of microorganism, and it doesn't follow this typical variety of microorganisms here, then if we make that change in the math, what does that result in? And we found, not we again, this is before I was involved, they found that that sometimes you could pass the verification experiment, but your SAL does not calculate 10 to the minus 6. It's still extremely safe, but does not hit 10 to the minus 6. So we got to call that a pass-fail. And what they found was this pass-fail scenario tended to only occur in the very low bioburden counts. So if you look at the table on the right, you see those bold, it's kind of hard to see probably, the bold pass-fails are occurring at 0.1 CFU per product, and a couple, I guess one in 0.105, and then one in 10.69, with one particularly, the MD stands for modified distribution. So these are, they're taking the standard distribution resistances, tweaking the numbers and seeing what happens. Recently, John Kowalski and I did some additional assessments where we're changing the numbers in a different way, and we found the same thing. As you tweak the resistances of microorganisms on your product bioburden, occasionally you're going to get a scenario where the verification dose experiment passes, but you're not hitting 10 to the minus 6. And then this is made a little bit worse with only having a 10 sample verification dose experiment like we have for VD Max, as opposed to a 100 sample. Just because the sample size is smaller, and if the sample size is smaller and your bioburden is very low, you might have all 10 samples of the 10 samples you send for the verification dose experiment, you might only have one that carries any bioburden at all, or maybe all 10 don't have any bioburden. So when that's the case, you really don't know if you're passing the verification dose experiment because the resistance is where it should be, your bioburden resistance is where it should be compared to the tables, or if it's because there is no bioburden present. Now you might think, well, the bioburden is super low, does it really matter? And that's a valid point. But we're just trying to be safe. Now, radiation, it is a bioburden-based method. So that means that bioburden is critical. And because of that, compared to other sterilization modalities, we should have an increased focus on both bioburden numbers and types. And so when we talk about numbers and types, when we're talking about types, we're talking about bioburden characterization. We're going to talk more about that in a minute. So here's some the updated text. In 7.2, it still says shall be demonstrated, but then says including characterization and establishment of bioburden alert and action levels. The intent was always that characterization be performed, which does not mean identification of genus and species. It's just characterization is some understanding of product bioburden, that what types they are, and establishing bioburden alert and action levels. Notice I'm not saying limits, I'm saying levels, because levels is the appropriate term. So that's the new shall. Include that the shall is to include characterization and establishing alert and action levels. And in the annex 7.2, we have this statement that the demonstration of stability in bioburden numbers and types is critical for radiation sterilization, since it's a bioburden-based method. Okay, now shifting gears just a little bit on a slightly different topic regarding frequency of bioburden testing. Instead of requiring for different bioburden counts that you have to perform bioburden testing more frequently or maybe less frequently, then the minimum requirement is essentially once a quarter, which is what it used to say. But the problem was the previous text said every 3 months, and we were seeing some regulatory bodies or even internally in companies saying, well, I'm at 91 days instead of 90 days, so that means my product is non-sterile, or I haven't started my dose audit yet, I'm in severe trouble. That is not the intent, never has been the intent. So to open that up a little bit, it's a little bit not super straightforward, but we hope it provides that opening that we think companies needed to not have regulators or internal quality or regulatory people be too nitpicky on is it 90 days or 91 days. So we say 4 times per year, we want 4 dose audits a year, but not exceeding 4 months in between time. So hopefully that gives some flexibility there to meet the intent the way it's always been. And then also in 12.122, bioburden. So now we're saying, okay, we're not requiring you to do bioburden testing more frequently than every 3 months, but there would be instances where that would be important. And here's some examples: high level variability in the product bioburden, or if they're limited data, if you have no history of the product, or if the bioburden is less than, the sterilization dose is less than or equal to 17.5 kilograde, then you should consider either increased frequency of bioburden testing or increased bioburden characterization, or both. So that means instead of the standard dictating what to do but not saying why or how to interpret the data, now we're saying you have to decide. It's on you. You need to determine this. So how do we do that? Well, in the annex in 7.2, we added a text here that you need to have personnel that are competent in microbiology and sterility assurance. This is another concern that we've had in the industry. We've made the radiation process so simple. There are just a handful of steps, and you just go through the steps, and once they're done, then you consider yourself finished. And unfortunately, oftentimes people are carrying out these really critical responsibilities, but that have no microbiological or sterility assurance background. It's not through any fault of their own. It's usually because they say, hey, you're in QA, so let's just have you tackle sterilization as well. It's radiation, it's easy, we'll have you do that. And we wanted to make sure that it was clear in this new version that you need someone who's competent in microbiology and sterility assurance. And we're going to talk about that a little bit more in just a bit. So also in A7.2, we talk about, I read that previous statement that demonstration of stability in bioburden numbers and types is critical. So in the annex, we have demonstration of stability in numbers is quite simple. That's establishing alert and action levels and checking those, make sure the levels are good, and making sure that you're falling within those levels. So I'll give you a couple resources here. So looks like about 12 years ago, some colleagues and I, and then a friend from FDA, Harry Bouchard, we published an article in MBDI on establishing bioburden alert and action levels. And it tends to be very helpful. We just provide some main concepts to look at. So if that's helpful, feel free to look that up. Also in chapter 64, so Seymour Bloch for decades is kind of his book on disinfection, sterilization, and preservation has kind of been the Bible for what we do. And chapter 64 also contains information on this. But in stability and bioburden numbers, we might need to test more than 30 samples initially. So like in your radiation dose establishment, you're testing 10 samples from 3 batches. That might not be enough depending on the situation. And then to immediately go to 10 samples once a quarter, again, that might not be enough. So stability and bioburden types is more complex. We talked about numbers, now types. And this requires an understanding of microbiology and resistance to radiation. We talk about demonstrating it empirically, only based on data, or empirically plus microbiological knowledge and literature. So different ways that you can establish this understanding of bioburden types. And again, like the phrase here, competent microbiology and stability assurance personnel, we include in here. And then, so how do we, let's say you want to become a competent microbiology and stability assurance person. What are your resources? Well, clearly there are lots of seminars and workshops you can attend. Nelson Labs, we hold quite a few in-person workshops every year, and where we go into a lot of detail on this. Amy has a really good seminar just on radiation sterilization. It's about 3.5 days, 4 days, and sometimes I help teach that. ASTM is getting a little more involved on the microbiology side, but if you want to understand the big picture of radiation sterilization, ASTM has a lot of good information, including a workshop they hold every few years on radiation dosimetry. But other ways, so if other people you can involve. So of course there are consultants. There are lots of consultants. It can be hard to pick good ones that really have the background, but there are some really good ones. Your contract laboratories and sterilizers, they should have people that can help give guidance. Amy has the CISS, a Certified Industrial Sterilization Specialist class, or not class, sorry, certification on radiation. They give you a list of topics to review or standards and documents. And then also the Society for Sterility Assurance Professionals, SFSAP. That's still in development, but there's an extensive amount of information there on what it takes to build competency in radiation and in microbiology. So what might this look like? And this is all information that's in the new annex of part 1. More in-depth bioburden characterization. So selective plating or culturing, gram stains of predominant colonies, spore formers, IDs of get identifications if you have pink, red, or orange colonies. Those tend to be the most radiation resistant are colonies that exhibit those colors. And then based on your knowledge now that you've gained of identifications of predominant or radiation resistant colonies, then you can use literature. I say to use it wisely because a D value that you get in the literature might not apply to the way it is on your product, but it gives you a general idea. Is it highly resistant? Is it medium resistance? Is it likely low resistance? And you should always ID all sterility positives. Any positives you get in your test of sterility, you should always identify those and understand what's there. And then greater sample sizes for verification dose experiments. This is listed as an option in the new standards. So for example, You can just test 10 samples from multiple batches. So it's the same verification dose. Each group of 10 has the same acceptance criteria, but you can test it on multiple batches instead of only on one to gather that more complete information of your product bioburden and resistance. And then you can also just calculate a verification dose for 30 samples. So AMI TIR 76 has a calculation tool. There's a link in the annex. You can go to that link and you can calculate a VD max verification dose for any sterilization dose and a variety of sterility assurance levels, and you can calculate a dose for 30 samples. So these are just options on how to gain more information on the resistance side of your product. Let's go through some examples, and then we'll go into some Q&A. So here we go. This is a new product, a brand new manufacturing location. So this is a lot of new stuff. On the left-hand side here, we're talking about what things do you try to figure out to understand what to do. So you already know there's no bioburden history. Some of the employees are existing. There'll be some new ones. It's a medium-sized product. There are different material types and components. There's one subassembly that is sourced from the supplier. And you did find that there's water involved in one manufacturing step of this whole process. And the plan is to manufacture one batch every 2 weeks. And based on this, whoever you have as your knowledgeable sterility assurance person, they expect this to be about 50 CFU per product. So not a high bioburden. And I'm not saying that your people need to guess the number, but I'm saying that they should be able to look at it and say, we expect this to not be in the hundreds. It should not be zero, probably somewhere in the middle. Okay, so with this information, how do we get extensive product bioburden knowledge so we can be properly establishing our radiation dose? Well, we already talked about getting the right people, both internally and externally. And also your suppliers. And if you're not auditing them in person, at least a really good remote audit, if at all possible. But this is not, if you want to do this correctly, this is not a quality audit. This is a technical, microbiological, and sterility assurance audit as well. Make sure you have people with technical background in radiation sterilization that are doing these audits so you can understand how much your suppliers might be influencing your ability to successfully complete your radiation process. Now, water. Some of you probably know water can be your greatest enemy in manufacturing of healthcare products. So water should certainly focus heavily on process controls and monitors in that water process. And you want to understand what the lab is proposing as far as the bioburden test and the sterility test methods. And initially, since a new location, you should be gathering a lot more environmental monitoring than you plan on doing routinely. And what might you look at then for bioburden? Well, let's say you're doing one batch every 2 weeks. Maybe you could perform bioburden testing on every batch for the first 3 months. Let's get some good history here. It's important to understand you are establishing a history for hopefully decades of manufacturing. And you're establishing a baseline for that. And this is a critical time for you to really understand what the product bioburden is at this point. So in the future, you have good data to compare back to. So maybe you perform testing on every batch for the first 3 months to gather data over time. Now, do you test 10 samples? Do you test 5 samples? Those are good questions on every batch. You could gram stain all the unique colonies. It's not a really high bioburden product, and gram stains are inexpensive and fast. So you could gram stain all the unique colonies and put that in your library. You can identify the 3 most common colonies from every batch. So you're getting what you're seeing most often. What are those microorganisms by genus and species? Add that to your library. Are any of these resistant, like any pink, red, or orange microorganisms? Have those identified, even if they're present in low numbers. And then look at the standard deviations. What kind of spread do you have in the bioburden data? And then in this case, we want to use VD max 20. So again, to help establish this good baseline, instead of performing verification of this experiment just on the one batch, you can do it on 3 batches like we talked about before. It's the same acceptance criteria, 10 samples just from 3 different batches. You can irradiate them all at the same time. and just see over multiple batches how does that turn out. And then again, identify all those positives. Okay, so let's shift now to bioburden type stability. So this is a new product and an existing location. And I'm just going to kind of touch on a couple things on these next few slides here so we can make sure we have time for a good time for Q&A. So in this case, there's no history for this product, but it's an existing location. You have good data there, mostly same employees, smaller product, and assembly is all in-house. There's no water in the process. You plan on manufacturing 1 batch a week, and you're expecting this bioburden to be pretty low, so about 15 CFU. Well, your people are established. You've got the environmental control of the area and all that. That's good. Say if there's a new supplier, check that. Otherwise, you're good to go there. Bioburden and sterility test methods are all established with your other product types. So what might you look at here? Maybe you perform one bioburden testing and characterization on 1 batch of product each month for the first few months. Again, your sample size is variable depending on what you think would be helpful. And I still think since you have a low bioburden count, you expect the count to be really low, you can gram stain every unique colony test for your library. You can still identify the top 3 is very common from every batch, and look for resistant bugs. And then again, look at your standard deviation, you look at your bioburden spread. Again, looking at using VDMax 20. So it seems like in this situation, performing a verification dose experiment on a single batch is probably sufficient. Probably no need to do anything more because of the extensive history you have with the location, the manufacturing process, etc. And again, identify all positives. Now let's take the previous slide, tweak it just a little bit. In this case, you're saying that you expect the bioburden to be about 0.5 CFU. So we expect it to be very low. Like out of testing 10 samples, we only expect to see any growth, any colonies on just a few of those plates. And it's an inexpensive product that has some radiation sensitivity, so you want a nice low sterilization dose. So in this case, then we'd say, well, maybe you perform bioburden testing on characterization on every batch. And the first few batches, test 10, but test them individually so you can prove what you expect, which is that bioburden is low and that in most cases you don't see any colonies. But when you do see colonies, you only see 1 or 2 or 3. You don't see a bunch of zeros and 100 CFU. That you see low counts when you do see them. So you gather these data initially and then say, okay, we want to see what is our bioburden. When we have bioburden, what is it? So the next step then, after your first few batches, is then test the next 5 batches, for example, test 30 samples pooled from every batch. So you're taking all 30 samples from the batch, you're increasing sample size, putting them into 1 bioburden test container, or maybe 3 groups of 10, whatever works, but you're pooling so you get more samples tested, and now you're just looking for bioburden. And when you see bioburden, what are the counts and what are they? And then the verification dose experiment of 17.5. Again, here it could be wise, because your bioburden is so low, it could be wise to test over multiple batches. So you're doing still sample size of 10, but on 3 different batches, just to try and make sure that when you see bioburden that it still is falling below the standard distribution of resistances. Okay, and then so this is the other extreme. You have a new product in a family, existing location, existing product family, all is the same. This product is just slightly different size compared to other ones. So you're adopting this product in the new family. What's required here? Well, largely probably nothing. One thing that we're adding to the new version of part 2 that I might have time to talk about depending on your questions is more detail and radiation part 2 on family grouping and product adoption specifically. So in this case, if everything falls into line, you might not need to do any bioburden testing or characterization. Or if there are any questions, maybe do a bioburden test on 1 batch just to verify that what you expect is the case. But with regards to a verification dose experiment, if it fits in the family nicely, likely no additional testing required. Okay, I'm going to talk just for a moment about, I'm not going to go through everything here, but previously, the standard had a term that was called the specified bioburden limit that was thrown out in a few places in clause 12. And there was no definition to what the specified bioburden limit was, but obviously it was critical as it kept popping up and talking about if you exceed the limit, then you shall do this and that. And but there was no established term. It was confusing, so we took it out in the new version of Part 1. And for some people, they thought, well, maybe if you're using VD Max, that specified bioburden limit should always default to be the maximum value on the table. For example, 25 kilogray is 1,000 CFU. That is not the intent, and that should not be a default limit for testing, or sorry, for bioburden results going forward. And again, that's something else I can talk about with more time on a separate discussion. The new version says just change that to an established action level. So you can set that action level appropriately, whatever makes sense to you, and then you're good to go. Okay. So thank you for your time. We will do some Q&A now. Let's see, Mike, you're gonna...
Yeah, thank you, Martel. Thanks for that great presentation. We do have some questions, so I don't want to waste time. We'll just get right into it, and we'll try to answer as many audience questions as we can right now. So if you're ready, Martel, here's the first one. Okay, why do you recommend to pink, red, and orange colonies and not white, yellow ones?
Okay, good. Through decades of experience, we have found, this is not just me and Nelson Lab, this is all of us in the industry have found, the most resistant microorganisms to radiation are not spore formers. They're not staph, they're not E. coli. For some reason, the most resistant bugs are those that tend to carry with them these bright pigmented colonies. So pink, yellow, pink, red, orange. There is some association there, but there is those are the ones that are most resistant. And so that's why we want to focus on those if you see those.
Okay, here's the next one. It's a little longer, so bear with me. A new concept, stimulated product, has been brought to ISO 11137. I think it's supposed to be simulated product. I want to know what the acceptable criteria are to use the simulated product for the dose map. Does it accept to use of the same material and weight of the subassembly and same packaging as the simulated product for the dose map, considering it takes a long time to manufacture the products?
Okay, so that I can speak to that fairly well, but I'm not an expert in dosimetry. But it's a good question because dose mapping, there's a lot of new information regarding dose mapping, or some new information on dose mapping in Part 1 as well. So if we can get that person's, if we have their email address, then
yes, we do.
I'd like to connect that person with one of our dosimetry experts, and they can give a better answer than I could here.
Perfect.
Okay.
Here's our next question. As far as I understand, verification doses based on bioburden levels have been established using standardized statistical data on the radiation resistance of microorganisms. Regarding the strengthened requirements of microbial identification, is this considered separate from the existing ISO standards, and is it based on the increased possibility of emerging strains with higher resistance to radiation?
Okay, so the concept of identifying microorganisms that grow in your test of sterility that is done as in your verification experiment, that has always been good practice, and it's many of us have always strongly recommended it, and it's still not a requirement, but it's still a recommendation. But when you see growth in your verificationalist experiment, those are the bugs that are the ones that if your bioburden were to shift to where you're seeing more of those than you saw previously, that could be a problem for you. You're already seeing growth. You're passing. You're only getting 1 positive or 2 positive in method 1. So you're passing, but you're right there, and it could push you over and get too many positives. So that's one reason why it's critical. The other comment there, the other topic is, are we seeing a shift in radiation resistance? We are not seeing a shift in radiation resistance, meaning we're not seeing all the microorganisms getting more resistant to radiation. But what we do see is there are a couple of new types of bugs that we didn't see 30 years ago when I'd started. So Deinococcus radiodurans is one that we've seen off and on for a long, long time. We're seeing that sometimes a little more frequently due to manufacturing processes of raw materials. There's a methylobacterium that I remember seeing for the first time, I don't know, 20 something years ago. And then one of the newer ones we're seeing is Roseamonas. It's a gram-negative rod that's pink or red on the plate. And so we are seeing some bugs that are showing up a little more frequently than we used to. So it's not that all the microorganisms are becoming more resistant. I don't want to give that scare. That's not the case. But there are certain bugs that, due to manufacturing processes or sourcing from different locations around the world, that we're seeing that do show up a little more regularly, a little more often. We're still seeing, by and large, most products are still passing just fine. But we are seeing those more often. I hope that answers the question. If not, you're welcome to reach out and we can talk in more detail.
Great. Thank you, Martel. Here's our next question. If a shift is observed in the types of microorganisms without a change in the count, is this considered a significant stability concern?
Yeah, it can be. If you're seeing a shift from 1 gram-positive cocci that's yellow to gram-positive cocci that's white, that's not likely a concern. That type of thing you'll see quite regularly. What you don't want to see, for example, is if most of your bugs previously were skin type bugs, a lot of gram-positive cocci, yellow, cream, white, and then you're seeing this shift to where now you're seeing lots of gram-negative rods that are, a lot of them are pink and red. That's the type of shift that's a big concern. When the source of contamination seems to be changing, for example, from skin bugs to water bugs, or from skin bugs to environmental bugs, if all of a sudden now you're seeing a lot of spore formers and a lot of yeasts and molds, that's an indication that your route of contamination of bioburden on the product has changed. And so yes, that should be a concern.
Great, Martel. If you don't mind, we have a lot of questions. Maybe we'll go a few minutes.
Let's keep going.
Over. Okay. Here's the next question. How would these new updates be applicable to products that are still in development, yet to be commercialized?
Okay. So I'll give an answer. Well, if it's not good enough, let me know. But there is, if it's not commercialized, that's actually an ideal situation, because you're not having to go back and say, well, did we do enough characterization previously or not? You can just decide now, here's how you're going to approach the appropriate characterization of bioburden. And I don't anticipate, for example, FDA saying, or other regulatory bodies coming out now this month and saying, hey, you haven't looked back at every product and shown good characterization. What I expect they'll want to see, whether it's a new product or an existing product, I expect they would just want to see, what is your plan? What is your approach? Who do you involve? And how do you plan on demonstrating good stability in bioburden numbers and types, and then going forward with that plan? I don't anticipate anything having to be done after the fact. That's my guess.
Okay, thanks, Martel. Here's our next one. How should manufacturers approach risk assessment when seasonal changes are observed in bioburden levels and profiles?
Yeah, seasonal changes are interesting. My experience is, in most cases, I tend, and I'm sure this does happen though, but in most cases, what I tend to see is shifts in bioburden, not because the temperature or the humidity has changed outside as much as the fact that time has passed and you have new people or more people, or practices have shifted. But regardless of the cause, whether it's just the passage of time and changes that occur with time, or the fact that the weather is changing outside, there can be changes there. And that's why in radiation we have you do dose audits 4 times a year, so that you capture the passage of time and the change in seasons. And when we talk about increasing the frequency of bioburden testing, or increasing how much you're doing bioburden characterization, I don't think you have to do that for a full year so you gather that whole duration of time. I don't anticipate that being the issue. In most cases, you're manufacturing in controlled environments. The reason we control environments is so we can minimize the impact of seasonal changes on the product. So hopefully you don't see wide shifts. You should not. If you do, there might be an issue with your controlled environment. So I think that's why, and the examples I gave, if you gather this initial data over 3 months' time, but if you do see issues, if there are things that are not avoidable, then you can lengthen that time, so you can decrease the frequency of testing, but lengthen the time, for example, over 6 months, where you're doing a little more than what might be required, but still more to gather data to address what might happen over time. I hope that at least gives some ideas on that one.
Perfect. Okay, here's our next one. When a sterile product is sold with 2 sterile barriers, meaning 2 packaging, is it right to test also the first packaging material together with the item for bioburden?
Yes, that is a question we get regularly. The answer is no. I realize, and we talk about this as an industry, and we have these discussions with FDA personnel in the room, that there's a note in the radiation standard that says, in most cases it's appropriate to discard the packaging and to only test the product unless the packaging is an integral part of the product. So for example, in most cases you would not test a backer board, you would not test a racetrack for a catheter, you would not test the inner pouch or the primary sterile barrier system, even though the outer pouch might have the sterile claim on it. The world knows you're not putting the packaging inside the patient. The intent is clearly just the product, and it really complicates matters both at the test lab and interpreting bioburden data if you're testing the packaging and the product together. If you must test the packaging for some reason, test it separately so that you really understand the influence that packaging has on the overall product bioburden. But as an industry, we all seem to agree there's no need to test packaging along with the product routinely. If you want to test it initially, just understand what the bioburden counts are, great. But don't test it with product routinely. There's no need for that, and that's why we put that note in it's in radiation standard. It's also in the bioburden and the sterility standard. So 11737-1 and 2 also has that similar note that generally it's appropriate to not test packaging.
Okay, we'll keep going a little bit more.
Great.
Would it be appropriate to set a bioburden action based on characterization?
Oh, okay. Yeah, there could be some wisdom there. That I would not expect you or see a real benefit in getting too detailed there. For example, I would not want to say see results where it's our alert and action levels are X and Y for overall bioburden counts. But if we see pink, red, or orange, our alert and action levels are A and B. I think that's getting too far. But I think there's a lot of wisdom in having alert and action levels, but then adding to that any bugs that are pink, red, or orange, regardless of whether they show up in bioburden or sterility, those should be identified to genus and species, and then you can get an idea from the lab. You can ask them, when you see pink, red, or orange bugs, identify them and tell us how many colonies you saw of that color. Not so you can set levels, but just so you have an understanding of what percentage that is of your overall bioburden count.
Okay, on to the next. Can you explain more why 1,000 CFU wouldn't be considered the specified bioburden limit in the previous revision of the ISO standard?
Okay. You know, for a while, I even thought that might be appropriate. And so here's, those of you that are familiar with method one, maybe this will help explain that. With method one, you have a bioburden count, you have a verification dose, and a sterilization dose. As the bioburden count increases, your verification dose increases, and your sterilization dose increases. So for example, and I don't know offhand, let's say your bioburden count is 20 CFU, your sterilization dose is 18 kilogray. In method one, you would never say, well, when I established my radiation dose, my bioburden count was 20 CFU, the sterilization dose I'm using is 18. 18 corresponds exactly to 20 CFU, which means going forward, if I get 21 CFU, I'm in trouble because I'm higher than the bioburden count that corresponds exactly to my sterilization dose. Now, if we think now in VD max, okay, VD max has this maximum value. For example, 25 has a max value cap at 1,000 CFU for 25 kilogray. For 22.5, it's 220. Every VD max table has a set value in the table that you're not supposed to go beyond. But the intent there is that's the case for dose establishment. When you're establishing dose, if your count is higher than that value, you should go to the next higher table and use a higher dose, or fix the bioburden problem, get it lower, so you can use that lower radiation dose you want to use. But that's only meant to be for dose establishment. Once you are doing dose audits, there is not an expectation, there should not be, because there's no scientific reason that, let's say in VD max 25, if my bioburden count is 800 CFU, I can totally use VD max 25. I'm below 1,000 in the table, but that does not mean that in the future that I can't allow some flexibility there. There is no magic that says at 1,001 CFU, you're going to fail your verification dose experiment. It's always a combination of numbers and types and how resistant those types are. So 1,000 CFU of 25 kilogray, that is a cap during dose substantiation for VD max, but it is not meant to be a cap going forward. You might allow some flexibility above that if you've properly assessed the alert and action levels. Now, if your bioburden is 5 CFU, I think 1,000 CFU is too high. I think you should never have any level at 1,000 CFU if you're trending at 5 CFU. So that's why I say it should never be a default value for the future. It's only meant to be a default value for establishing dose. I hope that clarifies that.
Perfect. I think we have time for maybe one or two more questions.
Cool.
So here we go. What would you recommend when there are bioburden results passing based on average, but a couple of individual results fall in the alert level?
Yeah. Yes. This is another discussion that we have quite a bit at both the AMI level in the US and at the ISO level for the international side of things. There is no expectation that action be taken or any activities occur when one or two values are above the level. We are all about averages with regards to radiation sterilization, that you're going to get a fluctuation in bioburden count. There's no expectation that if you have one or two above your alert or action level, that there be any specific activity. Now, and the reason why, if it's high enough it's going to be a problem, it will bump up the whole average to be at or above your alert or action level. If it's just a value or two, if you want to, you can do some, you have the lab say, is it all one bug? Is it a bunch of different bugs? Maybe do some characterization if you want to, but there should not be, I would not recommend having a lot of detail around specific values. We should focus on averages, and because that's the way the standards are done, and that's the expectation.
Okay, this will be our last question. When bioburden frequency is recommended no longer than 4 months since previous bioburden, do you still need to perform bioburden in a quarter that you do not manufacture products? For example,
Good.
can you speak to the bioburden frequency when the manufacturing only occurs 1 or 2 times a year?
Yeah. Fortunately, we've anticipated that question. And so there actually is a statement, I can't quote the clause, but there is a statement that says that if product is not manufactured during a 3-month period of time, that there is no requirement that you manufacture product just to perform the test. You are fine just to hold off. When the next batch is manufactured, that's when you implement, or that's when you initiate your bioburden testing, and probably your dose audit as well. So Mike, if we're cutting off here, so you see my email there.
Yep.
So you are more than welcome to send an email. What I'm going to say is, don't say, hey, I've got a question, can we set up a time? I'm going to say, just send me a meeting invite. If I can't make it, I'll tell you why, and we can work on a time. But the meeting invites automatically pop up. I see them on the calendar in case it's mixed up in the 100 emails I've gotten that day. Just send a meeting invite. I'd be happy to talk to you, and hopefully I can make it work, or we'll change the time for sure we can talk. So I look forward to those opportunities.
Well, great. Thank you, Martel, and thank you for that offer, and thank you for your insights on this updated and revisions to the standards. Got a lot of great information today, and thank you to the viewer for all of your great questions. This webinar is being recorded and will be available in the Sotera Health Academy and on the Nelson Labs website here in the next day or two. So we thank Martel, our presenter, and we thank you, the viewer, for attending this session. We hope that you found it to be a valuable experience, and have a great rest of your day.
Thank you, everybody.